Hello and welcome back. Finally, we have reached the 12th code of our 12 codes for ECG interpretation, which is the U wave. Unfortunately, U wave is usually absent, but sometimes you can see it. And I want to emphasize that when you see the U wave, be sure that it can confuse you with an abnormal B wave. So be sure and differentiate between the U wave and the B next coming B wave. This is the first point. The second point, when U wave is present and you are going to calculate the QT interval, usually you add the U wave to the to the T. So you calculate from the start of the QRS complex to the end of U wave. Why? Because U wave represents repolarization of the Purkinje fiber. So it is part of the repolarization process. So it should be involved in the QT interval calculation. Usually, if it is present, it's a small wave less than 1.5 millimeter in amplitude. I mean, less than 2 small squares in its amplitude. Usually, prominent U wave seen in patients with hypokalemia, always associated with long QT interval, but also may be present in situations of hyperkalemia, cytotoxicosis, exposure to digoxin, or antiarrhythmic medications with pro-arrhythmic effect like class 1C, class 1A, sorry, and class 3 antiarrhythmics. Also, it is present in situations with long QT syndrome and in cases of intracranial hemorrhage. So it may be present as a benign condition, especially in young patients, and if it is present, never confuse it with a B wave. And when you are calculating the QT interval, be sure to involve the U wave in your calculation. Usually, when prominent occurs in situations of hypokalemia due to repeated vomiting or diarrhea, as in cancer patients, but also may occur in patients with hypercalcemia, cytotoxicosis, with some antiarrhythmic drugs, with pro-arrhythmic medications, in long QT syndrome, and in situations of intracranial hemorrhage. So to summarize our 12 codes for 12 lead ECG interpretation and take it as in a stepwise approach, the first thing is to be sure of your connection and calibration. You at first look at AVR. If it is negative, so your ECG is properly connected. Look at the normal calibration to squares in amplitude and the speed 25 millimeter per second, so normal calibration. Then exclude presence of any artifact, calculate the heart rate, look for the rhythm in the form of every B followed by a QRS complex, look at lead 1 and AVF to determine the axis of the heart, then start interpreting all parts of the image. Start with the B wave, its morphology, amplitude, and duration. Go to the PR interval, either prolonged or depressed. With PR segment, is it depressed or elevated? Look at the QRS complex morphology, if there is a bundle branch block, amplitude, if there is a ventricular hypertrophy, duration for its prolongation. Then look at the ST segment, is it ST segment elevated or ST segment depressed, or it is normally isoelectric. Then look at the T wave, it is a hyperacute T wave or it is inverted, flattened, or small. Finally, eventually calculate the QT interval to see if it is normal, prolonged, or shortened, and finally search for presence of a U wave. By following this stepwise approach, you will interpret the ECG in an accurate manner. You will be able to obtain as much of knowledge as you can, interpreting the ECG in the background of a clinical context to reach a provisional diagnosis and confirm it with other diagnostic workup. I hope that I helped you in catching the basics of ECG. I have worked to make it in a practical manner to give you to the point knowledge to help you in your clinical daily practice. Also help medical students for passing their exams, especially board exams. For more advanced details, you can build up upon this course, and for sure in the coming period, we will prepare a more advanced levels. Thank you very much for your patience. I wish you a fruitful, successful future, and see you.